the morning. Her usual wake up time used to be 5 or 6 before marriage, but she gets up by 3 and then she's unable to, or 3 or 4, and unable to go back to sleep. On asking if there's anything else which is disturbing her is the fact that 6 weeks prior to the presentation, she started having some difficulty in, the urine issues, which is, she was experiencing some burning in micturition. So there was no fever, however, but there was burning in micturition, and this used to cause her to get up frequently in the nights. She's been taking on and off antibiotics. So with this history, she's come to us, and when you analyze this history of 4 months, which is not too chronic, it's neither acute, there's a change in personality and behavior. There's a change in, speed of work. And it's the underlying is disturbed sleep. So one would tend to think that, there is some urinary tract infection also because of the burning micturition and the fact that she's been consuming antibiotics. But this has only come later. So the problems with change in sleep and personality came since 4 months. And she says virtually this is the story almost every night. Only when she's relaxed and she doesn't have to get back to work the next day in the morning, there her sleep may be a little better, but otherwise it's definitely throughout the week. So it's like 24 by 7, 7 days a week, or maybe 5 days a week. So one would tend to think that she definitely has a condition which is causing a neurobehavioral syndrome, something which Dr. Ravi sees very often. It's also something we see as neurologists very often. They are brought to us with cognitive complaints, and it's usually becoming slow and indecisive and memory issues. But the underpinning is a 4-month history of, a broken up sleep or disrupted sleep. So when you get this history, what are the things that run through your mind? So first of all, you'll think that she probably has an insomnia, and the fact that it's occurring more than 5 or more than 3 days in a week for more than 3 months makes it a chronic insomnia. Second is she has a history of getting up with a start, and we haven't yet examined her, but she's a well-built individual. We haven't yet seen her BMI. This is just the history. So one would think whether she has OSA, that would be the next thing, because she's getting up with starts, though the husband, has not reported snoring. And if you really look into the history of your patients, the husbands really never report anything. The husbands sleep better than the wives, I suppose. And if you ask the husband, does she snore? They give a blank look, they haven't, they're sleeping better or whatever than the wife. So the husband had really never observed her snoring. And very often for women who have OSA, I have to tell the husbands to make a recording in sleep of sounds around the bed. So OSA is one possibility because of her very good body build. Then there are other possibilities. We did ask her whether she was having any, excessive dreams or, feeling of not being able to move in sleep when she gets up with a start. However, she denies any history of, excessive dreaming or some vivid dreaming or hallucinations or any sleep paralysis. So narcolepsy is another condition in which the sleep can be highly disrupted. So that will be much lower down in the probabilities. Then, of course, comes the fact that could it be that she's not able to get to sleep and there are some movements in sleep. So we did take the history of any burning or any tingling or any, abnormal sensation in the feet just before she goes to sleep, but she denies that. So obviously, restless leg syndrome is not a possibility, though that is a very, very important cause of, insomnia, particularly sleep onset insomnia. So restless leg syndrome symptoms are taken in the history and that's not there. The other thing that can cause disruptions in sleep, which the patient is unaware of, is periodic leg movements. So usually periodic leg movements cause a unrefreshing sleep. That is, in the morning when they get up, they are not fresh. Now this lady, neither her husband who bought her along with, she came along with him to the clinic, has observed any jerking of the limbs in sleep. Periodic leg movements can cause disrupted sleep because they are occurring at intervals. And at least history-wise, this is not available of, sequential, series of movements in sleep. So I don't think it's periodic leg movements also. Anything else? Would anyone want to consider a shift phase disorder? That's one of the disorders. No, but it doesn't sound like a shift phase because she hasn't, we'll go into the history, but she doesn't have any, sleeping at 3 a.m. and getting up at 11 or 12, or sleeping at 6 p.m. or 7 p.m. and getting up at 2 a.m. That kind of history, or she doesn't have any regular kind of free type of circadian shift disorder history. Could it be a seizure? Seizures will cause disruption in sleep, and they will occur multiple times in the night. And the history given by Dr. Ravi Gupta to me was that she gets up multiple times in the night. So seizure is a possibility, though she's never had any event while awake. So this is a very important factor for distinguishing interruption in sleep due to a seizure versus a primary sleep disorder. A seizure causing sleep disruption will occur multiple times in the night. In which part of the night? In the early part of the night. Usually in the stage 2 or stage 1 of sleep, as the patient is going into sleep in the first cycle or the second cycle. Seizures don't occur when you have to get up. But the history she gives us is she gets up even at 3 a.m. So it's unlikely to be a seizure based on the timing of the events which are happening in sleep. And also, seizures don't happen early in the morning, because early in the morning you are into dense REM. And REM is anti-epileptogenic. The REM by itself causes neuronal desynchronization. The neurons are just not synchronized. They are all over the place. So seizures will not happen when there is a neuronal desynchronization. Seizures usually happen when there is a synchronization, which is seen in non-REM sleep. So obviously the fact that, she's, again, this is a possibility that seizures are not there. But however, we cannot rule it out. Other strong factor that this is not a seizure which is causing frequent awakenings in the night is the fact she's never had any event in the morning time. It's in seizures versus a sleep issue. Generally, there will be some escape seizures in the morning hours while she's awake. That has never happened. There's never been urinary incontinence. There's never been any tongue bite. So really seizures are, I don't think Dr. Ravi was thinking of seizures when he gave me this case. So seizures are out. Last but not the least is parasomnias. So parasomnias can also cause awakening in the middle of the night. But you will not get multiple awakenings, isn't it? Parasomnia is usually divided into 2 types. One is a non-REM, one is a REM. So the REM parasomnia is going to be dealt by someone in the next case, I think, or next to next case. So REM parasomnia will occur more towards the morning hours, whereas here she is getting interrupted sleep throughout the night. And a non-REM parasomnia will occur in the early part of the sleep. But do you get multiple non-REM parasomnias in the same night? You don't. So the history given by Dr. Ravi to me is that she's getting up multiple times in the night. So parasomnia will not occur like that every night, 3 to 4 times getting up is due to a parasomnia. And then which parasomnia will cause that? Okay, early part of the night you get up in somnambulism. Or you could, get up in a sleep terror. So neither is it like a sleep terror, nor is she in the age bracket of a sleep terror. Usually occurs in children, and there's not any autonomic discharge. So I think that is also out. A parasomnia is also out. So essentially we are left with 2 conditions. One is a insomnia, which is chronic, and the second is a possible OSA. We are not sure of that. So let's go further into the history. She's 28 years old, and nowadays, girls are getting married quite late. So she's just been married for 8 months. When you get married, there's a change in schedules. There's a lot of adjusting to be done, mostly by the girl rather than, the boy's side. She's a working woman, just like most people are nowadays. And her usual routine prior to marriage used to be to sleep by 10, because she has to get up in the morning and go for work. But now she's been married into this family, which is a joint family. So this is not uncommon that the parents and, maybe the sister of the groom is also staying in the same household. So there's a lot of, adjustment, social issues, as well as interpersonal issues which come up in such a scenario. And she's just been married for 8 months, which would be relatively, new marriage. This household which she's come into has different wake and sleep times. You'd be surprised. Her husband is a businessman and he comes home, and he has to be given food when he comes home. So obviously he's coming home at 10 or 9:30, something like that. And then he has to be given food, and then everything has to be wound up and you have to shut down for the day. So she's sleeping only just by 11, maybe even later than 11. And previously she was sleeping by 10, 9:30, 10. So there's a change in timing. And the husband is quite considerate. He says that, okay, if you feel sleepy, you sleep off. But the in-laws kind of stare down her throat and say that, you aren't staying awake. Your husband, when he comes, he has to open the house on his own. So there's a lot of concern by the parents that she's not looking after the husband. So there's a shift in the sleep timing for her. And next day she has to report to work by 8:30 max. Nowadays you have all biometrics, even at AIIMS. So you'll find everybody rushing in, and they had a jolly good time in COVID when the biometrics was pulled down. But she has to report with a biometric at 8. So she can, if she's sleeping at 11 or 12, she just barely manages to get up by 6 after finishing all the household chores in the morning. So the chores in the morning would be what? Like making the breakfast, packing the water and the food for the day, both for herself and her husband, and going out. Fortunately, she still doesn't have children. And her father has COPD, and he has chronic cough, which continues throughout the night. It's a small home, 2-bedroom. So you can hear the cough all through the night. As well as the mother-in-law is wheelchair bound due to severe arthritis, which is not uncommon in our families. So there is a lot of logistic work which she has to do in the morning, which is expected by her to put her mother-in-law onto the wheelchair and get the mother-in-law fresh, apart from getting herself fresh. So she's been pre-morbidly before marriage, just as any girl is. Most girls are very anxious and a high achiever. They want to do the best for themselves as well as their work environment. So she's always been like that. And she's had similar complaints, but infrequently in the past. Like when she was, taking up exams, it was like her nursing exams. So at that time also, she was unable to sleep for a few days, but it didn't continue for 4 months or 3 months. It was for a few days. So really, this is her history. And when she comes back from work, fortunately, she's in a clinic job, so she doesn't have to do a night shifts or anything. She's just on a fixed schedule. Like sometimes they have to do shift duties, which is not there for her. She comes back, she has again to do all the household chores and, make sure everything is ready for the next day. So a pretty packed day, both for her at work as well as, at home. So again, this would reinforce to us that there is, would you say she's getting an inadequate opportunity to sleep, or she's getting adequate opportunity to sleep? She sleeps by around 11, gets up by around 6. Is that adequate or inadequate for a woman who's 28 years? A 28-year-old lady, she's a young adult. So normally you should be able to get 7 hours at least, isn't it? If not 8, 8 is a luxury. So she is getting kind of 7 hours. So the opportunity to sleep is adequate. It's not that she is sleep deprived. Would you call her sleep deprived? Not yet. So that's the first criteria. You should have an adequate opportunity to sleep. How many of you all are residents here? Okay, and how many of you all do night duties? You do. So if you're in a profession which requires you to do night duties, then maybe you're not getting an adequate opportunity to sleep, especially if you have a 36-hour cycle. Like many of our residents have to do a full day duty and then again come back for work. So, however, for her, it's not like that. She's getting enough time to sleep. Despite that, she's finding it difficult to sleep. So at this point of time, any of you have a doubt that she has a chronic insomnia? None of you are doubting the fact that she has a chronic insomnia. Okay, good. So why did it get stuck? Okay. So she's become slow, and generally when a person becomes slow as a medical person, you always think whether she has any features of hypothyroidism, because that's pretty common nowadays. So generally, she's not got a cold intolerance, nor is she constipated. And so clinically, at least, she has no features of hypothyroidism. And this was confirmed by the thyroid test. Mind you, in a patient who's coming to you with a sleep complaint, please do the thyroid. You will find that there's severe hypothyroidism in patients with OSA. And sometimes just correcting that hypothyroidism resolves to a certain extent the degree of OSA. It's a reversible cause of sleep apnea. So all patients who have a sleep complaint must get a T3, T4, TSH done. And you'd be interested to know that there's a certain autoimmune thyroid syndrome, which is known as the autoimmune thyroiditis, where you can get high TPO antibodies, which also causes sleep disruptions. So in a patient who's insomniac, you should get the TPO antibodies also, because high TPO antibodies are associated with insomnia and sleep disruptions. There's another autoimmune syndrome, but not related to thyroid. It's called the IGLON5 autoantibody syndrome, where the primary presentation is insomnia. So they present with insomnia. But however, she doesn't have the other features. So her thyroids were normal, her TPOs were normal. She's vegetarian. Now, vegetarians are known to have a neurobehavioral syndrome if they are deficient of B12. B12 deficiency is the commonest cause of a neurobehavioral irritability and a slowness and sometimes even depression and anxiety. So if you're finding a vegetarian who's changed in personality, you have to go ahead and do a B12 before you say it's primary insomnia or whatever, insomnia. So her B12s are normal. Her ECG is normal. That's another thing which can cause anxiety, certain rate and rhythm disorders. Her BMI is 27. Now, 27 is what? Above? 27 is overweight, you would say, or obese? Obese, okay. So there are different criteria of the West and for Asia, for India particularly. So you would say anything about 25 to be obese. However, in the West, it's 29. So anything under 29 and you're overweight, you're not obese. I don't know why people are so unkind to us Indians. So in the West, 29 and above is obese, whereas here it is 25 to 29. So she is obese, though she doesn't look obese. She generally looks, she doesn't have a very thick neck. Her Malampati score is not high. It's just a normal. Everything is seen in the oropharynx. Her pulse rate is 98. Her blood pressure is 128/86, which is normal. Her skin is kind of dry, but not too dry, and respiratory rate is increased. It's 18. She has pallor, and we apply the insomnia severity score, and she scores 22. So where would that be? 22. So anything above 15 is something which is to be noted, okay, and cannot be ignored. So basically why I showed you all this is that in insomnia, it's not just saying ki, okay, neend nahi aa rahi, pill likh ke bhej do. You have to examine all these systems, maybe even more than this. Maybe I've missed out something here, and Dr. Ravi or Dr. Tripathi can tell me what I missed out, or Dr. Deepti can tell me what I've missed out in this. But general physical examination is very important in an insomniac. Believe me, there are many conditions which are reversible. And once you put them, blindly, many physicians will put them on a pill and send them away. It's very difficult to investigate, and they really don't come back to you for the investigation. They just keep continuing taking the pills. So taking a good history and ruling out general conditions like hypothyroidism, low B12, cardiac conditions, etc. is very important. So I told you the differentials which we considered, and the top, of course, the diagnosis still remains pretty clear. It's a chronic insomnia. However, I think we have kind of ruled out all of these possibilities. Would any of you like to consider any of these possibilities still, or can we throw them in the dustbin? We can safely throw them in the dustbin, except the fact that, she's a little overweight or whatever. So OSA is a possibility. Now, the American Academy of Sleep Medicine as well as the DSM-5 have clearly stated that when you get a patient with insomnia, and this is a standard of care, you have to define everything. You have to tease out the history. So in this patient, there was a difficulty mostly of maintaining sleep in the history. She was getting up frequently. She was also getting up early. So there was an early morning awakening. Like she was getting up at 3 in the morning at times and not getting back to sleep, sometimes getting back to sleep. And she also had a difficulty initiating sleep at times, particularly when, she was sleeping and then the husband comes and then she's disturbed and she has to look after the husband and then go back to sleep. So she has the complete spectrum, but mostly difficulty maintaining sleep. Now, why is this important in the management of insomnia? Because if you are planning to give an intervention in the form of a pharmacotherapy, you have to know the half-life of the medicines. If you give a medicine whose half-life is just say 2 hours or 1.5 hours, you are not going to be able to satisfy her sleep demand because she has a difficulty maintaining sleep. So you have to know the pharmacokinetic properties and the dynamic properties as well as the half-lives of your medication. And when you get a patient who has across the board a sleep onset, sleep maintenance, as well as early morning awakening, you have to give drugs which are either extended release formulations or have a long half-life. At the same time, you have to be careful that there is no next day hangover. So this is very, very important. There are very few drugs with that kind of, duration of action. And that is why this part of the history is very important as to which phase of the night she is not getting sleep.
Ma'am, sorry to interrupt. Please keep track of time.
Okay. I was told I have 45 minutes, so I was going very, very aramse, but I can hurry up. So basically, you will have to take all this and I'll just hurry up. And in this, of course, you have to look at medical complaints, and medical complaints, we did get a factor, which was a urinary tract infection. She's not too heavy on caffeine. She takes 1 or 2 cups of coffee in a day, sometimes just 1, and 1 or 2 cups of tea in a day. And she does not have irregular shift. So basically, it's very important to remember that even though insomnia has got something to do with sleep, it can cause significant problems in your next day functioning. And that is an essential criteria. To say insomnia, the next one of at least the next day functioning should be impaired. So all these things can happen. You can meet with accidents because you're sleepy at the car, or you can be confused in thinking and judgment. You can get easily upset, irritated, and annoyed. And if anybody dissects the road rage cases on the roads of Delhi, you will find only 2 things in these patients who are having road rage in Delhi. That is, they either have inadequate sleep or they are insomniac. Then, of course, I told you the AIIMS recommends. So that is what we did. But the AIIMS recommends that you must have a complete physical examination and a mental status examination. So you just don't believe her that she's become slow and her memory is reduced. You will have to do objective scoring. And the objective scoring, if you're planning to publish, is to do either the MOCA in Hindi or to do the ACE in Hindi, because the MMSC in Hindi is chargeable. If you publish without asking for their permission and without paying, they'll send you a notice after the publication and ask you to withdraw the publication. So please don't do the MMSC unless you've paid for it. This is very, very common. So there are several factors which we need to understand when we are understanding this young lady: the biological factors, the psychosocial factors, which she has enough, and socio-cultural factors, which are particular to our country. So this young lady who has insomnia with increased vaso, which probably is there, is probably affected, by many things. So what is it that we will investigate? We just can't believe her history. So you will, in the first visit, you will tell her, okay, medication will come to later, but you please take the sleep diary. All of you have heard of the sleep diary. So again, this is this is for the ASM. The ASM has clearly said that you have to give them a sleep diary. All sleep patients must go home with a sleep diary. And the ideal is to maintain it for 2 weeks, but some of them are so distressed that they'll get back to you in 1 week. If you're doing a research study, yes, 2 weeks or more than 2 weeks, whatever. But commonly, if you have to manage a patient, then if I tell an insomniac, you come back after 2 weeks, they will either not come back to me or they'll go to some, physician who will very readily prescribe them the pill. So for insomniacs, I don't tell them to wait so much. I tell them कि आप 2-3 दिन या 1 हफ्ते का note करके आओ. And in the meanwhile, I give them a very mild medication. We will talk about the mild medication. So you have to apply the sleep-wake diary. You have to apply the insomnia questionnaire. In few cases, you may apply the actigraphy. And this is particularly when there is an entity which is known as paradoxical insomnia. Have you heard of paradoxical insomnia? There are some fuss spots who will keep telling you, I'm not sleeping, I'm not sleeping. And you ask the bed partner, see, to soti rehti hai, bahut achhi soti hai. And the lady is saying she's not sleeping, or the man is saying they're not sleeping. But the corroborative history is that they're sleeping. So here you want an objective evidence, but you don't want an objective evidence like calling them to the PhD lab. Because believe me, calling an insomniac to the PhD lab, there will be an extreme first night effect. They will never get sleep. Whereas an OSA in the PhD lab generally gets sleep. So you will give them the actigraph, which will tell you whether they are actually sleeping or not. So for paradoxical insomnia, actigraphy is a must. Otherwise, in all other insomniacs, unless you're doing a research study or you're doing a pharmacotherapeutic intervention study with some new medicine, you need to do actigraphy. Otherwise, routinely, we don't do it. Dr. Ravi are doing routinely. So routinely, it's going to be painful if you do actigraphy. And of course, sleep study is also not indicated in insomnia. So, but it's indicated when you suspect OSA or when you suspect a narcolepsy, cataplexy. Cataplexy may not be there. It may just be a narcolepsy. There also you have to do a sleep study followed by MSLT. And also when you suspect PLMs, which are causing unrefreshing sleep associated with or without OSA or RBD. RBD requires a polysomnogram. Okay. So this is just to show you the ISI. It's very, very simple. And this is what the history we say. So please rate the current severity of your insomnia, difficulty falling, staying and waking up early. How satisfied or dissatisfied are you with the current sleep problem? To what extent do you consider that the sleep problem interferes in your daily functioning? How noticeable to others do you think your sleeping problem is in terms of impaired quality of life? And how worried or distressed you are about your sleep problem? And anything about above 15 is a clinical insomnia. And of course, our patient had 22, so which was severe insomnia. So she comes back with a sleep diary, and you can see here. What do you see? This is where she goes to bed. The dash is where she goes to bed. On the weekends, she's going late. Okay, obviously, because there may be some events at home or outside. So she's sleeping almost after an hour or 2 hours. So there is a delayed sleep onset. What is the sleep onset latency for normal adults? It should be 10 to 20 minutes. Within 10 to 20 minutes, we should be asleep. But sometimes, definitely within half an hour, you should be asleep. But here, she's awake for 1 hour and 2 hours. So she has a delayed sleep onset. Then in between, at around 3, as she told in the history, she's getting up around 3 or 4. And she's staying awake for a huge amount of time, 1 hour, 2 hours, as you can see here. And sometimes, she gets up early in the morning and then stays in bed for some time. So really, she seems to have what she told us in the history, a sleep onset, as well as at least in the sleep diary, sleep onset, sleep maintenance, as well as early morning awakening. This is her actigraphy. We did her actigraphy because she's part of a study which we are doing for a Ayush compound for insomnia. And you can see she has frequent night awakenings in the actigraphy. So she fulfills the criteria, at least one criteria from A and one criteria from B, and objective evidence of the same. So let's skip slides. I don't think, how much time do you have? Okay. So now let's go to this. It's in managing the patient. We still have some 10 minutes. It's very important to find out the 3 Ps. And these 3 Ps are like the Bible of insomnia, which is otherwise the Spielman's model. And really, it's a very good model because it helps you identify and tease out each factor. So you have to find out her predisposing factor, you have to find out her precipitating factor and a perpetuating factor. So anybody in the audience can tell me her predisposing factor? What is her predisposing factor? I told you in the history, she's a very ambitious person. She's a high achiever, a little anxious in personality. And there is a change in the circadian rhythm also. So the predisposing factors are there. And maybe there's a little bit of coping also because she's changed her household. What is the precipitating factor for her? Anything precipitating? There's environmental. Her father-in-law is coughing through the night and her mother-in-law is to be looked after. Then, anything else precipitating? Pardon? Yeah, so that also comes under environmental. Perpetuating? Anxiety could be. I think precipitating factor, her urinary tract infection should also be factored in. Because since 6 weeks, she's having a UTI for which she's, obviously UTI is another cause of frequent visits to the toilet when you, after sleeping. So I think she has all these factors and we need to individually work on these factors. If you just work only on one factor, it will not be there. Okay, you say tum bahut chinta karti ho and you send her on alprazolam, it will not work. You have to modify and you have to educate them about these factors. इसकी वजह से आपका शुरू हुआ, इसकी वजह से आपका बना हुआ है और इसकी वजह से ये खत्म नहीं हो रहा है. So I think that should be understood because once you're a chronic insomniac, you've crossed a threshold beyond which the factors just perpetuate. Then you have to work on all her mechanisms. She probably is in a hyper-aroused state because of her anxious personality. So you have to work on that. She has, worry over sleep loss because that is what has brought her there. And then there are consequences. She's having mood disturbances, behavior disturbances also. So you have to work on the hyper-arousal. I will not go through this theory part of it. Insomnia is very, very common in women. And you can see here, if you have previous insomnia. So do you think this lady had previous insomnia? Yes. She was giving a history of previous insomnia, isn't it? There was a history of previous insomnia in that when she was facing exams, she would find it difficult to sleep. And even around the exam, she would find it difficult to sleep. And she had, though she would get an opportunity to sleep. But this was not chronic. It was an intermittent or short-term insomnia. So in chronic insomnia, please go back and take a history of intermittent insomnia. Because in patients who have a history of intermittent insomnia in the past, the prognosis is a bit different than a person who does not have a history of intermittent insomnia in the past. So let's see how to manage this patient. So the patient came to me, I gave her a sleep diary. And you will notice I allowed her to fill it only for 1 week. I called her back after 1 week. I said, uske pehle bhi aana hai to aa jao. So that she doesn't go and get into some wrong medication. So what would that medicine be which I give her for 1 week? I shouldn't give her any medicine when she has to fill in the sleep diary. Is it clear? You can't send her insomnia. That's why that was a trick question. You cannot give her medicine when you've asked her to fill in a sleep diary because the sleep diary is going to get modified. So always treatment name, and that is why you will call her back early. Then the first medicine you would like to give her is not a medicine. You would like to suggest certain interventions in the terms of cognitive behavior therapy. Or we have our indigenous therapy, which we have researched in with Dr. Malik in AIIMS. So you would like to give her that, but invariably, if you do not give her a pharmacotherapy when she comes back with the actigraphy recording and the sleep diary, what is going to happen? She's going to again go elsewhere and get a wrong medication written. And as sleep doctors, it's very important to start the patient on the right medicine. So the first medicine I started her on was, which one will I start her on? Mild, very mild, physiological melatonin. So I told her, I'll give you a very mild medicine. I also at that point of time educated her that sleep medicines are not good in the long run. You probably need to take it for 4 to 6 weeks and then stop it. And the reason we are starting on a mild medicine is that if you improve with a mild medicine, you don't need the, the more heavy medicines which are expensive. So we started on melatonin, 3 milligram. Some people start with 1 milligram, but in my experience, 1 milligram never works. She took it about half an hour before bedtime, and she came back a week later with melatonin. She said, this is not helping me. In the meanwhile, I told her to do Yog Nidra, and because we don't have the luxury of having a CBT. Why? CBT is expensive. Every time CBT requires 6 to 8 cycles, and you need a dedicated person doing CBT. And every cycle of CBT costs the patient 1,000 rupees. I don't know here, but in Delhi, they're even going up to 3,000 rupees. So 3,000 rupees into 8, it's very expensive. So we promote the Yog Nidra. So we gave her that. And when she came back after a week, the Yog Nidra hadn't kicked in. But I changed her medication. So I think the chairperson is getting restless. I changed her medicine. I don't want to. So changed her medicine to the newer ones, which is Davigo, which is Lambrexant, 5 milligram. So the advantage with Lambrexant is that it is a, what is the advantage? It is a DORA. It is a dual orexin receptor antagonist. Dr. Malik just told you orexin is a wake promoting substance. So you're antagonizing the wake promoting substance. You're not working by enhancing the inhibitory substance. This is one molecule where for working people, particularly those who are driving and who have to get to work fast, it is good because it has been tested out for daytime balance, nighttime balance, as well as for driving. So 5 milligram Davigo, we gave her for 4 weeks, and following which we could bring it down to 5.5, which is like 5 one day and half one day, which is not generally recommended, but we did that for 2 weeks. Then we brought it down to 2.5 alternate day. And then we got her off it within a span of 8 weeks by when the Yog Nidra had kicked in. So Yog Nidra we find is very useful. And if they're able to do it, they can find a lot of improvement with it. So this is just to show you another patient who actually had OSA with the vaso. So you can see the vaso, excessive vaso, and delayed sleep onset, and also had a severe sleep apnea. I don't know where the PhD study has gone. Okay, this is the one. Okay. So the sleep apnea treated. So basically, I'll conclude by saying that this patient had a diagnosis of chronic insomnia. And I think insomnia, if properly managed, is the most gratifying to treat of all sleep disorders, because the patient is very, very happy. And I think psychiatrists will understand that better. But for all of us who have sleep issues, managing insomnia successfully is the most gratifying. And the catch point here is that sleep clinicians need to generate awareness in the community that they have to consult sleep physicians. They should not be getting over-the-counter alprazolam or over-the-counter benzodiazepines, which actually make it very difficult to wean off. Some of them are on nitrazepam, some of them are on clonazepam, some of them are on alprazolam, and all these 3 substances are highly addictive. Another word of caution, if you strongly suspect OSA, as the last patient had, please, before you start on a Z drug or you start on a DORA, please do a sleep study, because you don't want to worsen OSA, which is causing insomnia. So I'd conclude by that. If there are any questions, I can take them.
So I think it's a thought-provoking case discussion by Dr. Tripathi.